Wasting of the small muscles of the hand is a very important clinical finding in neurology and internal medicine. The key is not only to recognize the wasting, but to localize the lesion. It may be in the peripheral nerves, brachial plexus, nerve roots, cervical cord, or anterior horn cells. So always identify the pattern first, then localize the lesion. Small muscle wasting means loss of bulk of the intrinsic muscles of the hand. The important areas are the thenar eminence, hypothenar eminence, and interossae, especially the first dorsal interosseous. Clinically, this can reduce grip, weaken pincer movement, and impair fine motor tasks. So this is not just a hand finding, it is a localization problem. On inspection, look carefully at both hands from the dorsal and palmar aspects. Look for hollowing of the first dorsal interosseous space, then R wasting, hypothenar wasting, clawing, deformity, and fasciculations. Also ask about function. Difficulty buttoning clothes or writing tells you the intrinsic hand muscles are clinically weak. The key anatomy is simple but very high yield. The small muscles of the hand are supplied mainly by C8 to T1 fibers. The median nerve mainly supplies the thenar muscles and the lateral two lumbricals. The ulnar nerve supplies most interossae, the hypothenar muscles, and adductor pollicis. Remember, thenar is mainly median, interossae and hypothenar are mainly ulnar. In history, first ask, are the hands painful? Painful joints with morning stiffness and deformity suggest rheumatoid arthritis. Neck pain or radicular pain suggests cervical spondylosis or C8 to T1 radiculopathy. Sensory symptoms in the index finger point toward median nerve involvement, while symptoms in the little finger suggest ulnar nerve involvement. Now examine systematically. Start with inspection for thenar, hypothenar, and interosseous wasting, clawing, swelling, deformity, and fasciculations. Then test motor function, grip, pincer strength, finger abduction and adduction, and thumb abduction and opposition. For sensation, compare the index and little fingers and decide whether the pattern is peripheral nerve or dermatomal. Localization should move from peripheral to central. First, consider median or ulnar nerve lesions. Then think about the lower brachial plexus, especially if there is shoulder pain or Horner syndrome. Next, consider C8 to T1 roots if there is neck pain or radicular symptoms. Cervical cord disease gives hand wasting with upper motor neuron signs in the legs. Anterior horn cell disease gives fasciculations without sensory loss. The causes can be divided into bilateral and unilateral. Bilateral wasting suggests a central, proximal, or generalized process such as cervical myelopathy, motor neuron disease, syringomyelia, hereditary neuropathy, or bilateral neuropathies. Unilateral wasting more often suggests a focal lesion such as ulnar neuropathy, median neuropathy, lower plexopathy, radiculopathy, thoracic outlet syndrome, or Pancoast tumor. These are the high-yield localizing pearls, wasting with fasciculations and no sensory loss points toward anterior horn cell disease or motor neuron disease. Then R wasting suggests median nerve or C8 to T1 involvement. First, dorsal interosseous and hypothenar wasting suggest ulnar nerve or C8 to T1 involvement. Hand wasting with upper motor neuron signs in the legs suggests cervical myelopathy. A good exam presentation would be, this patient has wasting of the small muscles of the hand involving the thenar, hypothenar, and interosseous muscles, suggesting localization mainly to the C8 to T1 segment. Important differentials include peripheral nerve lesions, lower brachial plexopathy, root lesions, cervical cord disease, and anterior horn cell disorders. The final rule is, localize before you diagnose.